aspects, I think, one of the most difficult aspects of kind of everyday care, which is the idea of deprescribing. So it's easy to start people on medications. Well, sometimes it's easy. Most of the time, it's easy to start medications. But how do you stop? When do you stop? And that's the idea of deprescribing. So we don't have any conflicts to declare. And these are the 5 different areas we're going to be looking at. What is deprescribing? Why should we deprescribe? What are some barriers to deprescribing? And we're going to look for your help with that one. What are some of the consequences of deprescribing? And then just how do we do it? What are the steps? What are the best ways of going about it? So I get to start us off here by describing what it is. And this was a definition I found in one of the papers I reviewed. Withdrawal of an inappropriate medication supervised by a healthcare professional with the goal of managing polypharmacy and improving outcomes. So we can kind of break that down. That's the idea. So it's a withdrawal of an inappropriate medication. So it's a medication where there is either no scientific or clinical justification. You don't know why they're on it. Maybe the patient doesn't know why they're on it. Or it might be a medication that at one point was useful, but is no longer necessary. So we see this all the time, for example, in treatment augmentation for depression. You've started them on multiple medications. They're now feeling better. Do you need to have them on all that medication, or are some of those no longer as appropriate, no longer as necessary as they once were? It's supervised. So this is something that is planned, that is deliberate. It's usually tapered. It's usually done in a systematic way. It's done step by step. And one of the goals is to manage polypharmacy. There is a simple goal of reducing the number of medications a patient is on, but it's also there to improve outcomes. It's not just we want you to take fewer pills. It's that we want you to take fewer pills and still feel at least as well as you're feeling now, and maybe even better. That it's intended to improve symptoms, functioning, and quality of life. So that's the idea. That's what deprescribing is, and that's what we're trying to do. What it's not is simply patients stopping medications, patients being unable to afford medication. And so, since you can't afford it, I guess we're going to stop it, or running out of medications or stopping all their medications at once, right? We see that, but that's not what we're talking about. We're talking about something that's much more deliberate, much more intentional, and much more provider driven. The provider is in control of this whole process because it's planned, it's systematic, and it's stepwise. So we're going to have some opportunities for chat, questions, or if you would like to unmute, that's fine. The first question is, why? Why do we even bother? So I've already started off by saying this is one of the more difficult aspects, at least in my practice, I suspect in yours. Why do we even bother trying to do it? So what are some of the benefits of deprescribing psychiatric medications or psychotropic medications? You can, if you want to unmute and just say your answer, that is great. If you're a slow typist like I am, that's probably preferred. If you are a fast typist and you want to put it into the chat, go ahead and do that. But why should we even bother to try to deprescribe medications in someone who seems to be doing okay?
I think, there's benefits to, like, sometimes with maybe like some antipsychotics, like, or I'm just using those as an example, but a lot of metabolic disadvantages. So, disadvantages to people gaining weight, kidney, liver function. So their overall health can be improved. Like ultimately, if they can not be on a medication, that's the ideal. If it's possible, if they're being stabilized, I guess that's an advantage that I see in my practice, because a lot of times we're dealing with the side effects. We're giving other medications to deal with the side effects of the medication we're prescribing. So.
Right. So the less time we can expose them to something, the less likely they are to develop a really serious side effect. I mean, back in the old days when we were using lots of first-generation antipsychotic medications, the longer they were on it, the higher the risk of tardive, and that's serious. So in the chat, we see decreasing side effects, improving financial health because someone's paying for all these medicines. It's and generally safer, right, to be on fewer medications. So absolutely. We want to reduce medications that have no benefit. because even if they have no benefit, they still have the potential of doing something bad. They still have the potential of side effects. They still have the potential of drug-drug interactions. Dr. Messamore, who I think has been on here sometimes, I've heard him say a couple of times, you know, a medication that has no potential benefit but potential adverse effects is also called a poison, right? So if we're giving them something they don't need and it's putting them at risk, we're not doing the best thing we can for the patients. Reducing unnecessary side effects and drug interactions, reducing unnecessary costs, and it's also making it easier for them to remember to take their pills. I am astounded every time I go over to my parents' house and they show me their weekly pill box, and they have, you know, 7 different containers for every day for, you know, it's an amazing number of pills that they're on, and anything we can do to decrease the number of pills, make it easier for them to remember, which makes it easier for them to adhere to what we're prescribing, I think those are all good things. There's also some kind of literature about that. And not only does it logically make sense, that there was a review of polypharmacy. Polypharmacy is associated with increased adverse drug interactions. Not a surprise, drug-drug interactions happen in there. Increased risk of falls, because one of the more common side effects is sedation or lightheadedness. It increases the risk of non-adherence. It increases the risk, it's associated with hospitalizations and with increased mortality. Now, is that because of the medications or because these folks are sicker to begin with? I don't know, but being on multiple medications that aren't necessary can't be helping. And polypharmacy is also associated with a reduced quality of life. Again, because of the side effects, because of the adherence problems, because of the financial things, it's just not good for the patient to have to be on all those different pills. So that's the theoretical things. That makes sense. That's what it should do. Does it actually do that? Well, there have only been a few studies out there looking at the effects of deprescribing. And what they do say is, yeah, it absolutely reduces drug costs. And that makes sense because you're not having to take so many pills. You're not having to buy the pills. Your insurance isn't paying for the pills. So deprescribing reduces drug costs. That's logical. Deprescribing does increase medication adherence by making it simpler, making the regimen easier to follow, easier to remember, fewer pills, fewer times a day. That's easier to remember, and deprescribing does that. They did 2 reviews, found deprescribing reduced the number of medications, right, which we expected, but led to no significant change in clinically important endpoints. So that idea of we're decreasing medications in order for you to feel better, that hasn't been so well described. We do know it decreases cost. We do know it improves adherence. It's a little harder to prove that patients actually feel better after deprescribing. At least 2 reviews found that it couldn't find that. And 1 review of 15 studies, so this is kind of a systematic review, 6 of them had improvement in outcome. So there was a direct benefit to deprescribing, but the rest did not. So even though theoretically it makes sense, logically it makes sense, if you just want to look at what the evidence says, deprescribing does help with some areas, but so far, you know, its effect on clinical outcome is a little harder to nail down. So we're going to use an example here as we talk about deprescribing and how to do it and why to do it. And not a real patient. This is all hypothetical, so no worries here. Miss Rao is a 47-year-old with recurrent major depression. She currently denies sadness and anhedonia, but is frequently anxious. Her sleep is frequently disrupted. She reports being both chronically tired and jittery and agitated throughout the day. She complains of chronic GI distress, but her weight and appetite are stable. She is worried about her future and her family members, kind of worries a bit, but not tremendously overwhelmed by it. No thoughts of death or suicide. And currently she is taking escitalopram, 20 milligrams a day. That was prescribed for her depression. She is taking sertraline, 50 milligrams a day. That was prescribed initially for anxiety. She is prescribed aripiprazole, 10 milligrams per day. That was prescribed for treatment-resistant depression. She is on quetiapine, 100 milligrams per night because of her insomnia, and she is on diazepam, 5 milligrams 3 times a day for her anxiety. So with that kind of brief background, with those medications, what would you consider deprescribing? Is there an obvious candidate here that you would think, if we need to do something, let's do this? What would you consider deprescribing?
I would consider starting with diazepam.
Okay, and why diazepam in particular?
Well, we already have two medications here to control anxiety. We got sertraline and we got diazepam. So the other option, of course, is is reducing the sertraline because we already have S-citalopram.
Right.
So why use both? And they belong to the same class. So I guess I would change my mind and say I would start with a sertraline first.
Okay, so
And because they already, these are two medications that belong to the same class and they probably work in the same way. So I would reduce it gradually and start with sertraline and then look at the next one would be diazepam.
okay, so we have a vote for sertraline. How about others?
I think I would start bringing up at least the discussion about the diazepam, that I'd like to start, the weaning process, while ensuring her somehow that she's doing well enough. I don't know. I'm sorry. I didn't notice if there was therapy here. Looks pretty medication oriented. So, I want her to get into some form of psychotherapy to further support her and start preparing her that we're going to start weaning off the diazepam nice and slow. If I have to put something under it, like an Atarax, I would. But
Okay, good. So any other thoughts? So we have sertraline we're looking at. We're a little suspicious about that. We're a little suspicious about diazepam. I deliberately did not have the therapy component. So we might add therapy on there as an option. Any other kind of obvious, not, and again, there's no one right answer for this, by the way, because again, it's a hypothetical patient. So you can hypothetically do anything you want, but what strikes you as being any other targets of opportunity here?
I mean, she's on 2 antipsychotics, which I mean the Seroquel is at a low dose, so it's not really, a huge target, but it's not really helping with sleep either. So definitely could, not something maybe necessarily that I would hit first. I think Zoloft is probably a good one to kind of maybe look at, because she's on the highest dose of the Lexapro and the lowest dose of the Zoloft, or the lower end of it. But yeah, trying to get them off of 2 antipsychotics would definitely be a goal of mine as well. But
Okay, good. So, right, we're starting to think, what are the advantages of these different medications? What are the disadvantages of medications? What are the particular side effects that we're looking at? How is it impacting her life? How do we help her feel better throughout the day? So good. Now, I think we would all agree that this is a good idea, right? That deprescribing, having them on the lowest number of medications just makes sense. Monotherapy if possible, but if not possible, then the least number of medications, the fewest, categories, not duplicating stuff as much. We all know that makes sense, but we all know that it's really hard. It's really difficult. What are some of the barriers that keeps us from deprescribing more frequently? Why is this not something we just automatically do, that we deprescribe almost as much as we prescribe? And I suspect that's true for very few of us, that we deprescribe as much as we prescribe. So what keeps us from doing that? What are the barriers here? And again, you can unmute, or if you want to put it in the chat, that is fine too. Well, I noticed I did miss a comment in the chat before when talking about what are the why would you want to deprescribe, and Crystal put in, many people want to feel like themselves and not feel like they're walking around with a lack of emotions or feelings and numbness that you sometimes get with those medications. So
I guess one thing that keeps us from deprescribing sometimes, if they're frequent flyers, inpatient, cycling between inpatient, outpatient, lots of medication changes are made in the hospital, and you might not necessarily want to mess with those. Vice versa, we're making medication changes, they go back in the hospital and then they switch up all their medications on you, so that can be a big problem.
Right. No, and that's a great point. when someone else has prescribed it, especially when they're coming out of an inpatient setting, and you don't know how necessary that was. You know, if you didn't see them right before they went in the hospital, that you don't know what they look like. You don't know how much improvement that caused. You're looking at it now saying it's unnecessary, but maybe a month ago or 2 months ago, it was very necessary. Okay, good. What else keeps us?
I think it may relate to some degree what you mentioned, what you were talking about last time, Dr. Weldon, is the just they might believe that it's helpful. They may have the belief that it's helpful, and it may not seem logically to be helpful, and there may seem to be logically more, side effects versus the benefits, but nonetheless, they might believe this is a part of their recovery process and therefore need to continue to use it.
Yeah, no, you can't stop my blue pill. I need my blue pill. They may not even know what it is, but the blue pill, that helps my, that helps my mood or whatever, right? So they believe that it's helpful, and so they might resist it. Okay. Any other thoughts?
Yes, there's another, I think, barrier that may come from the healthcare professional that is involved in prescribing, and that is if we're dealing with a patient that was prescribed the medication due to, let's say, an act of self-inflicted violence or an act of violence towards others, and the medication that the person is taking has helped to control it significantly, then the barrier is if we discontinue the medication, the essential symptoms, behavioral symptoms, may come back and involve a serious act that may end up in costing someone's life.
Right. They're afraid of that, and we're afraid of that.
Yes.
What if it is necessary? What if I'm wrong? What if I'm wrong in saying that this is an inappropriate medication and unnecessary to them? Maybe it is necessary. And I just would point out Alan's comment in the chat where he's taking the strong patient advocate position of, higher doses are always better and more medications are always better. But that's that belief. I want you to do something for me. I want you to help me, and you help me by prescribing things. So for patients, they can be afraid that symptoms will return or they'll experience withdrawal. In some medications, they might. Not understanding that connection between side effects and the medications they're on. So for example, in our previous patient, that jitteriness that she's feeling, maybe that's due to anxiety, but maybe that's drug-drug interaction. And if she doesn't know that, she's going to assume, what do you mean? I'm feeling bad. I'm feeling anxious. I'm feeling jittery. I have problems getting to sleep. What do you mean you're taking away a medication? You need to add more medications, not take something away, not understanding that jitteriness might be a result of a medication. And then habit, that belief that it's helping, that belief that it's necessary, it's worthwhile. And then for us, that fearfulness, and that had already been brought up a couple times, maybe that combination is necessary. We don't understand exactly how things work all the time. We don't have a complete understanding of neurobiology. Maybe there's a combination that's uniquely helpful for this patient, but also sometimes it's less positive motive. It's just easier and quicker to do nothing, right? A lot of patients are going to fight you on this, so it's a lot easier just to say, fine, whatever. It's probably not doing too much bad. We'll just continue it. We'll deal with it next time, and then we never do. And then there's lack of established guidelines to deprescribe. No one's forcing you to deprescribe usually. Now, sometimes like in hospitals, if you put someone on 2 antipsychotic medications, you're going to get dinged, right? Because that's one of the standards that they look at. And so there might be an incentive there to stop it, but not on an outpatient basis. No one's dinging you there. So just to realize there are forces that drive us to continue the medication, even when we think maybe it's better to stop. When is deprescribing more likely? Well, one, if the provider has to take an active role and probably initiate the discussion. Patients are very rarely going to come in and say, I don't think I need that Zoloft anymore. I mean, they might, maybe because of cost, maybe for other reasons, or maybe I forgot to take it last week and I feel just fine, you know. But usually if you're going to just deprescribe in a controlled, systematic, deliberate way, it's going to probably need to come from the provider, because the patients don't know what to suggest. It's all kind of mysterious to them, and they don't want to suggest that the provider's making a mistake by prescribing that medication, which is kind of what would be inherent if they say, I don't think I need this thing that you're giving me. So the provider has to start it. Deprescribing is more likely in patients who are better educated, and that's both in general, that they have a higher education in general, but also they're more educated about their medications, what the effect of the medications, what the side effect of the medications are. And it's more likely if there's shared decision making, that it's something that ultimately, after a discussion, they want and you want. If it's just you wanting it, it's probably not going to turn out well. If it's just the patient wanting it, you're probably not likely to do it. So it needs to be a shared decision. And with that, I'm going to turn things over to Dr. Dugan for a little bit and discuss the risks of deprescribing, because even though it might be a positive thing to do, it's not necessarily a benign thing to do. So I will turn this over to her.
I find it interesting. So as the pharmacist, I often end up having to talk about the negative side. So not the efficacy, but the side effects. So Dr. Welton's done a good job of kind of building the case of why we should be doing this. And I'm going to talk about what may happen if this gets done. And this is a list on the following slides. We're going to go into each of these in a little bit more detail, but there are a handful of risks. So as we're simplifying a medication regimen, drug interactions don't just happen when you add things. As things get removed, the body may have come to a new equilibrium. So that is something that we need to think about. We'll talk about the changes that happen if the appointments are no longer medication focused. A little bit about perceptions, which I think came up a little bit in the discussions that we've had so far. The recurrence, which definitely was identified. Other adverse effects. So sometimes those medications are covering up adverse effects, and as we remove them, we can see other ones. And the risk of withdrawal symptoms, especially related to the speed at which we do deprescribe. So looking at the first two, so the drug interaction. So if we're stopping a medication that we think either hasn't been useful or is causing adverse effects, we do really want to think about what has this been doing. I included pharmacokinetic adverse effects here. So there are medications that impact how the body metabolizes other medicines. So if we're getting rid of those, that means there's going to be a shift in everything else that's there. Two examples that I had identified here. So one is carbamazepine. So tegretol carbamazepine is one of our major inducers. So we may have had to increase the dose of a number of other medications because there's more enzyme to process it. Once we get rid of the carbamazepine, the body is going to stop having so much enzyme. That means that we are going to need to revisit the doses of some of those other medications. So if we've adjusted them up, we're probably going to have to adjust them down. Otherwise, they're going to start having some adverse effects. On the flip side, there are inhibitors. So medications that make the enzymes less effective and efficient at clearing other medications. Fluoxetine is an example. So if we're getting rid of that, fluoxetine is probably not the best example because it does have a nice long half-life. So it does take some time, but once it's gone, the amount of metabolism that the body can do is going to increase. So while the body couldn't process much of the drug, now it can process more. And we may see decreased concentrations and decreased effectiveness from some of those. So it is important that we at least appreciate the drug interactions if we're simplifying as well. Other changes, and I thought this was interesting. This popped up in two different articles that I was looking at related to deprescribing. So if you think about the relationship with some of the patients, so let's take a patient who's relatively stable. So their symptoms have been fairly well controlled. They've been on the same regimen for a longer period of time. You probably have a rhythm to what that appointment looks like. That may be a bright spot on your schedule when you see that this person's coming in. You're going to do a check-in, you know what to expect. It's going to flow in a relatively smooth manner. If we are looking at deprescribing, it's going to change some of those dynamics. So it's no longer something that's stable, that's expected, that you really aren't going to need to explore new territory. Well, if we are deprescribing, that may need to happen. The other thing that may happen is deprescribing isn't just for folks who are on multiple medications. It also can be done for folks who are just on a single medication. So once that medication has been discontinued, now if you're not talking about the medications, what are you talking about? So sometimes that change in dynamic can be really awkward and may take some time. It frees up time to talk about other things. Whether or not the patient's really willing or comfortable doing that in this type of setting is something that will need to be explored. So that is something to think about. It's not just going to be smooth sailing the entire time. Couple other risks for deprescribing. So what is the goal? Making sure that we're clear what is it that we're looking for. So I was listening very closely to some of the terms that were used before. Ultimate goal. The ultimate goal is no medications. Okay, that may be true in a general sense, but there are going to be a number of patients who have to be on something. And whether it be for their mental illness, whether it be for a medical condition, that really depends. There are several individuals who may be on blood pressure medication, and they say, well, do you have high blood pressure? No, I don't, because I'm on medicine for it. Well, no, you still have it, but it's helping get rid of it. And they may think that once their blood pressure is controlled, I no longer need that. No, my numbers look good. I don't have to take that anymore. So making sure that we're really clear and all on the same page for what is the ultimate goal. For the patient example that we just had, the goal may not be to get rid of everything. The goal may be, hey, let's simplify this a bit. It's a little muddy with what we're doing, and it's obviously not working because she's symptomatic. So really making sure that we're clear what the role is for the medication. I can't tell you the number of times for some of the pediatric and adolescent patients, they have multiple meds, and it's like, well, what are we using this for? Nobody knows. It's like, okay, well, there are symptoms. Are they better or worse than they were before? So kind of making sure everybody's on that same page and it's documented somewhere can be really helpful. And also letting them know that maybe we're not getting rid of everything. We're just trying to simplify, and then we're going to recheck and see what happens. The recurrence of symptoms, that was pretty well established in the discussion earlier. That is a risk of getting rid of it. So in the current example that Dr. Welton had, she is still symptomatic, especially on the anxiety side. So we may not like what that regimen looks like, but if we get rid of the sertraline, maybe her symptoms were much worse before that was started, even though she was on 20 milligrams of the escitalopram. So it's going to be really important that we're watching for that. I did try to find if we deprescribe, because there's not a great amount of literature for duration of treatment. Not everybody has to stay on treatment, even for things like bipolar disorder or schizophrenia, major depressive disorder. Not everybody needs to stay on lifelong treatment. But who gets to come off? That's what we don't know yet. We're kind of doing a guessing game. So I was able to find in the literature, so these are relapse rates after discontinuation of treatment. So for patients with schizophrenia, and this was relatively early onset schizophrenia, the relapse rates were about 77% over the course of a couple years. For bipolar disorder, it was 65%, and that was over the course of 18 months. And for major depressive disorder, it was 44%, and that also was over the course of a couple years. So also recognizing that, telling the patient, we're going to try to simplify this, but if symptoms come back, we may need to reintroduce some of these things. It also means no hurry. And the no hurry is super important. When I worked in New York at the Center for Disability Services, we had a number of patients who had been institutionalized, and they were on just massive doses of benzodiazepines. And we had a couple folks who just were really aggressive in trying to get them off. Yes, 60 milligrams daily of diazepam is a little much, but if they've been taking it for about 40 years, we don't need to get them off in the course of the next 6 weeks. And it was relatively unsuccessful in doing that. So we really want to make sure that we do this in a very systematic way, because if a patient's been on this medication for a while, as we discontinue it, we may uncover other things. I think the most obvious are movement disorders. So movement disorders associated with antipsychotics. It doesn't look like a patient has tardive dyskinesia, but as we reduce the dose of that antipsychotic, those symptoms may pop up. So it is something that we do want to be aware of. And if we do it too abruptly, it could be incredibly distressing for the patient. The other thing is we may not have realized that there were some adverse effects that the patient was experiencing, and they may not necessarily be withdrawal, but they may identify new things that we need to think about. A couple other examples I can think of. So patients who had maybe anxiety that were on more of a sedating medication, as we reduce the dose, even some of the antidepressants, you reduce the dose and their insomnia comes back. May not have been the main thing that we were using to treat that, but that may have been helpful for them. So that would be something we want to make sure that we're watching for any symptoms of their disorder, as well as any other new symptoms that may pop up. The other concern is with withdrawal effects. So abruptly or too abruptly discontinuing these medications and deprescribing them can result in withdrawal for a number of patients. I think our antidepressants are some of the best examples. So about 50% of patients who discontinue treatment end up with some type of withdrawal symptoms. That number can go up to 85% if they've been on high doses for an extended period of time. And it's about 3 to 5% experience severe withdrawal. And these withdrawal effects can be really uncomfortable and may last for months. So symptoms can be, they kind of feel like they have the flu, they may have a headache, they may be achy, they may be really fatigued, they may become anxious or agitated, they may be a little bit unsteady, they may be unable to sleep. They can get all kinds of burning, tingling, pins and needles sensations. So it can be really distressing for some of those patients, and it takes time for that to go away. And as uncomfortable as that is and unpleasant, it isn't quite as serious as for the benzodiazepines and our anti-seizure medicines. So if we stop those too abruptly, we can have withdrawal seizures. So that would be, and unfortunately in a couple instances, the one prescriber who was very much on a mission to get those patients off the benzodiazepine, we did end up seeing an exacerbation in seizures because they were way too aggressive. In some cases, we were dropping the dose in one. So diazepam, it was taken 3 times daily. We would drop the dose for a middle dose once a week. And we would do that for weeks at a time, just because some of the patients were so sensitive. So if we are going to deprescribe, we just want to make sure that we do it in a systematic way. So mitigating those risks, the awareness, making sure that they know what those red flags are, having those discussions, those open discussions, making sure that they can share that information with you, that shared decision-making can be huge. And then monitoring, making sure that objectively we know what it is that we're comparing to for both their previous symptoms as well as any new symptoms. So we're watching for it, but they're a great source of information, the patient as well as their family members, to be able to give us that information. So how would you do the deprescribing? And I'm going to turn this back over to Dr. Welton.
All right, thank you. Thank you very much. So this is an article about the 7 steps to help increase the likelihood that you'll be successful in deprescribing medications. And so we will walk through these steps. We don't take a huge amount of time. We'll walk through all of them. So the first thing is to collect a comprehensive medication list, which is sometimes difficult. You know what you're prescribing. You may not know what they're getting from other sources. I mean, it's helped with kind of electronic medical records. You have more access to what they're getting from other places, but still, they might be getting medications that don't show up. So the first thing is to collect that comprehensive list and then to walk through it. And this takes time. There is no way to shortcut this. review the indications and common side effects for all the medications that they're on. You're taking this is what it's for, this is the common side effects that you see with that. Are you experiencing those? And then start to correlate, if you can, their current symptoms and side effects to the medications that they're on. You know, I notice you're having, well, go back to my case here in a minute, agitation, jitteriness, akathisia can show up with aripiprazole. That's one of the side effects that we can see. So I'm wondering if maybe that side effect is from this medication. It's not that your anxiety is worse, it's maybe a medication. Or we have two different serotonin reuptake inhibitors. And that combination, sometimes if you get too much, it can lead to jitteriness. Maybe that's what's causing it. So you start to correlate the current symptoms and side effects to the medications that they're on. So go back to Miss Rao here. You know, your depression, the sadness, the anhedonia that was presumably there, that doesn't seem to be much of a problem anymore. What seems to be a problem is more the anxiety, the disrupted sleep, which leads to drowsiness during the day, and the jitteriness that she's experiencing. And that might be as a result of anxiety, but that also might be a result of the medications that you're taking. And several of the medications you're on are associated with anxiety, disrupted sleep, drowsiness, or jitteriness. So we need to take a look at that. So what are the medicines that they're on? What are the indications and the common side effects? And you start to work with the patient to correlate potential side effects with the symptoms they're experiencing. Then you list the options for change. What are reasonable options? We have identified in this patient several of them that are reasonable. And then you discuss the possible benefits and risks of change. Why might we want to do this? Why might we want to leave things well enough alone? And to go back to what Amelia was saying, you know, they need to be part of this conversation. They need to, you know, what is their opinion? What is their preference? You need to give them the information because you're the person who has the information, but they need to be part of the decision-making as you list the possible risks and benefits. So for Ms. Rao, again, maybe to decrease jitteriness, disrupted sleep, and anxiety, we decrease or stop one of her SSRIs that had been mentioned before. Maybe we decrease or stop aripiprazole, which can have akathisia. If she doesn't need that, that might be causing problems. For the drowsiness that she experienced during the day, well, maybe if we stop one of the things above, she sleeps better. And if she sleeps better, she's going to feel less drowsy. Maybe we decrease or stop the quetiapine, which can sometimes lead to daytime drowsiness. For her GI distress, maybe we decrease or stop one of her SSRIs. So these are all possible. These all have risks to them. They're all associated with potential risks, and we need to discuss them with her. And then we get to Amelia's point directly, exploring the patient's preference. Of those things that I've described, of those things that are possible, do any sound terrifying? Because we want to stay away from those. Or do any of those sound really inviting or really encouraging or something you might want to do? And then once you come up with that, you start to plan the taper. And Russell, if you had checked out the chat, another reason to do this. Russell, do you want to expand on that any, on your comment?
I don't want to interrupt your flow. It's just a thought I had. So
no, go ahead.
Oh, I was just saying that, you know, sometimes sometimes I think people, I'm a psychologist, so I don't deprescribe anything, but sometimes I'm in settings where deprescribing seems to occur as a function of program or regulatory requirements that may or may not make sense to the clinician or the patient who are kind of snared in that. And I find that that's oftentimes particularly challenging because there might even be misalignment with the provider in what that regulatory or program requirement suggests.
No, that's a great idea. I'm old enough. I remember people being refused substance use or alcohol rehab because they were on an SSRI. Or they were on an antidepressant, and that's a mood-altering drug, and you're not allowed in our program on a mood-altering drug. And yeah, we tried to fight that fight. So there's another reason, not necessarily a good reason or a valid reason, but it's a reason. So one thing that's also very helpful, and I do this with a lot of my patients, actually when I start medicine and when I stop and therapy and all sorts of things, is I'm always framing it as an experiment. You know, we've talked about why we might want to decrease this medicine, why we might want to stop this medicine. We've talked about what the risks of it are. We've talked about the potential benefits, but it's important to realize we're going to just monitor that and see if it works. Because, you know, we're at the point now where science has stopped. Science can tell us that this might be beneficial for you to stop this medication. But for you as an individual, we don't know. And there's no way to guess until we try it. And then we're going to monitor it and then see. And maybe it's a wrong decision. And if it's a wrong decision, we're going to start you back on. We're going to start you back on the medication. We'll start it back up. But maybe it's the right decision, but there's no way to know until we try it and we assess it. So you have a way of monitoring it over time. And what would warrant returning to the prescription? I had a patient one time who came to me on porcine thyroid. So actually they were, you know, harvesting the thyroid glands of pigs and monitoring it and giving it to her. And that was uniquely helpful. And she'd been on that for years and years. And it was not available where we were. And so, you know, we talked for months and months and then, you know, stopped it and said, you know, if it turns out it's a wrong idea, we will figure out a way to make it. It's an experiment. And, you know, after having been on it for 12 years, she stopped it and she said, I feel fine. So, you know, the experiment turned out well, but they don't always. So think of it that way. So, you know, again, I don't want to go too much in detail in a hypothetical example, but you know, the idea of, as I look at your list of medications, there are two that I'm thinking about. Your depression seems really well controlled. Your aripiprazole was started to control your depression, but it can also lead to anxiety, jitteriness, and problem sleeping. That might be worth stopping. And then, as several of you had mentioned, it's also usually not necessary to have two antidepressants that are as similar as sertraline and escitalopram. The sertraline is at a very low dose, but maybe that combination is, you know, causing GI problems or anxiety or jitteriness. You know, we could consider decreasing or stopping either one of those. We'd only want to do one, and we do it very gradually, and we would monitor your mood and monitor your anxiety and monitor your energy and monitor your sleep. But I think it might be helpful because I think it might help you feel better. What are your thoughts, right? And then that's part of the discussion. And the problem is this takes time. And if you're running behind and you have 6 more people out in your waiting room, it's hard to have that conversation, but it can be really valuable. A couple of last additional considerations before we throw it open to the group. Again, all of this is going to be helped if you have a good therapeutic alliance. So the stronger your relationship is with the patient, the more convinced the patient is that you're helping them, that you're working together toward a common goal, that you care about them and you hold them in highest regard and that you look forward to working with them. The stronger that therapeutic alliance is, the more likely they are to have a positive response. You, of course, want to avoid doing this during times of crisis or an acute phase, right? That's not the time. You can wait till they've been stable and doing well. Discuss and rank the different options because it's likely that there's going to be more than one option. So, you know, this I think is most likely. Would be my first choice, but we can do this other thing as well. Allow them to express their anxiety about the plan because if they think it's a bad idea, it's going to fail. Right? They're going to be calling you up within the next day or two and say, oh, this is a terrible idea. So they really have to be on board. And some authors were also suggesting you create a consensual and preferably written plan so that they know we're going to decrease this by this amount. These are the things we're going to monitor. And in a month, we're going to consider whether it's a good idea or a bad idea. If it's a good idea, we're going to continue decreasing this much. Anyway, you write it out for them so that, again, it's planned, it's structured, it's systematic. They know what to expect. So this is actually the last slide. And time-wise, we're not going to have time to break into small groups. So we'll do it as a big group discussion. What has been your experiences of deprescribing? When has it gone well? When has it gone poorly? What advice might you have for the rest of us that wasn't on my list? What, if anything, do you think you're going to do differently next time? So we are now going to turn to the group for the group wisdom. So I will stop